This conference will now be recorded.
Because she's going into other people's rooms and trying to elope and. Thank you.
Hi everyone, this is Emily from PSW. Thanks for joining us. We'll begin here shortly. If you are joining us, please mute your mic to limit the amount of feedback and background noise that we have. And as stated, we'll get started here in a few.
Shouldn't be. Well, they're cheap, they should still be.
Hello there, can everybody hear me?
Yes, I can hear you. This is Emily.
Oh, great. Oh, excellent. Okay. So it is 2:01. It looks like we still have some people joining. We have about 13 callers and then some more on the web. I'll just give another minute here. Are all of the people who have joined, are they muted?
Yes, and just as a reminder to folks joining us now, please mute yourself as you're joining.
Great. So just for some housekeeping issues before we get started, you guys are able to ask questions. You can use the messaging system, and those will pop up for me as I'm giving the webinar to answer questions as they pop up. So I will go ahead and introduce myself. I'm Dr. Jessica Van Fleet. I'm the Chief Medical Officer for Physicians of Southwest Washington. I also wear a few other hats, including being the Medical Director of Medicare of Lacey here in Washington State. I'm a Certified Medical Director with the Society of Post-Acute and Long-Term Care. And I also spend half my time with Multi-Care Health Systems with their population health program with Multi-Care Connected Care. So that is how part of this got started in affiliation with Physicians of Southwest Washington. And again, I know we have a lot of people joining from all over the country today. So for those of you who aren't as familiar with Physicians of Southwest Washington, we are a physician-owned population health company. And so my goal today is to talk a little bit about how we are managing COVID-19 from a population health-based perspective by going in and doing a lot of proactive planning with a lot of our facilities. So I'll give you a little bit of a background, and showing on the screen here is a picture from earlier this week serving as a member of a drop team for Multi-Care Health System. And this actually spawned out of the University of Washington. And they went in with Life Care of Kirkland to support that post-acute and long-term care facility. Sorry, I'm going to have everybody mute their line if they can for those who are calling in. So caller 18 looks like they're still not muted, so is 13. So if you guys can please just take a peek at your cell phone and go ahead and mute that. So University of Washington went in to support Life Care of Kirkland when they needed it and help support with triage and testing, both with their employees and with their affected patients. So several weeks ago now, myself and Lynn Steenstring with Multi-Care Health System had a conference call with those at University of Washington to talk to them about the purpose of their program and kind of how they stood this up. And what's different with the University of Washington is that they actually provide the medical management in 14 of their partner facilities. So very different from Multi-Care Health Systems and very different from Physicians of Southwest Washington, where there's not really a coordinating body. And so again, we are coming in from a population health-based perspective, from a public health-based perspective, and trying to be a coordinating body, of course, in conjunction with WACA, which is the Washington Organization for Healthcare and Post-Acute and Long-Term Care. But we have noticed significant regional differences with the public health bodies. So we made a commitment to go ahead and do this a little less than a month ago now, and we are fully up and running. And what the program involved was doing sort of preemptive talks just like this one to go into the SNF. So we did it mostly virtually and talk about preparation for COVID. We talked about cohorting, triage, kind of giving the basics. Again, the talk that I'm going to give you guys today. And what our anecdotal evidence shows is that there has been a fairly significant difference in those facilities that heard the talk and had the opportunity to plan ahead a little bit, and those facilities who have not. And so we saw differences in the spread of COVID. We saw the number of citations that they got from state agencies when they came in, and just the overall level of support. So that's the purpose of today's talk, is to really kind of support not only post-acute and long-term care, but any congregate facility, really. So if you're anything from adult family home or assisted living, or just a retirement community like our CCRC, we want you guys to have some tools in your toolbox related to this work. So again, I'll reference this picture that's showing up now. In reference to this work, we developed these drop teams that would go in if there was a facility in need. For this particular facility we were in, their medical director was quarantined and was not able to go in. So myself, and this is Dr. Jeff Clemens with Multi-Care Health Systems, and he is a urogynecologist who is not doing surgery right now. So him and I went in as sort of physician volunteers. We worked on cohorting, triage, segregation. We worked with the great nurses at this facility, and we tested every single resident in the facility earlier this week, and now have results with a fairly quick turnaround time, and confirmed that they do have 9 positives in that facility, but many other negatives. So there was a lot of benefit for segregation. So we can go ahead and progress to the next slide. So I already gave you a little bit of an introduction and a little bit about me and sort of how this idea started. I will go ahead and over the course of the talk give sort of the basics on COVID-19, much of which we know, but it has specific relevance to the work that we do. And so I want us to put a little bit of a myopic lens on our patient population as we look at these basics and how they can be applied, particularly from a regulatory perspective. So I also will talk to you a little bit about testing and supplies, as well as PPE, which we know is in shortage, talk about admissions processes, including capabilities, talk about the 1 through 4 categories that University of Washington, in conjunction with Swedish, developed in King County to, again, sort of take some of the pressure off the post-acute and long-term care facilities going through those admission processes. I'll then talk about cohorting, triage, and antechamber capabilities, as well as the admissions process, and then end a little bit with advanced care planning and shared decision making. So we can go ahead and go to the next slide. So I'll talk a little bit about the basics. Again, this is stuff that is out in the general media and most of us probably know, but again, if we put on our focus specifically on our facilities and on our patients, I think that it's important to get a little bit of a different perspective on this. So we know that the viability on plastics is about 72 hours, stainless steel about 48 hours, and cardboard 24 hours. Now, again, this was in a lab environment, so we don't really know what that would be if that was outside overnight or if it hit sunlight. But we're under the operating assumption that this has a fair amount of stability in the environment, which means that fomites are a huge driver for spreading infection, which is why we've, of course, been talking about surface cleaning so much. In our specific environment, I think it's really important that we talk about this and consider what things we can do as preventative steps. So I can tell you that one of the things that we did last week is we held mail for 24 hours, and that is our new policy going forward. So mail comes in, it gets held, there's packages, there's mail, maybe somebody has left an envelope, there could be some stability on that. So residents are not getting mail for at least 24 hours after it's been held, so we can ensure that the viability of that virus is lessened. So, of course, we had to QA that process. So for those who are on, we all understand this is a heavily regulated environment. Nobody wants to come in and get a site 6 months from now, an annual survey for widespread, not taking care of residents because they didn't get mail, and that potentially cause psychosocial harm. So QAing that process, using the evidence that this was recommended based on studies on viability of the virus, and then holding that mail, packages, etc. Also in line with what many hospitals have done, actually I think most of them have done now, is that we're not letting outside food into the buildings. So, nobody can go to McDonald's in the drive-through and then bring it to a resident. And of course, we know that that has issues with psychosocial harm. Patients really look forward to getting those surprises. But we know that it just isn't safe. We don't know who touched that. We don't know whose car it was in. We don't know who delivered it. So, and that has gone for our staff as well. So, people are not getting takeout and having it delivered any longer. So we just need to be very, very mindful of that, the surface viability of these. So I already commented that there's no studies on heat or cold, so we don't really know how environmental factors will potentially impact this. I will make a note that, again, most of us know this is more contagious than influenza. So when we speak in epidemiologic terms, we talk about the R0, that's listed there as R0. It's 2.5, and that's compared to influenza, which is 1.3. So real world terms on this is that if I get COVID tomorrow, I am likely to give it to 2.5 people. That is in contrast to influenza. If I were to get influenza, I would likely give it to 1.3 people. So we know it's about twice as contagious. And of course, we know that it is about 10 times more virulent. Important to note that as the denominator goes up, we expect the mortality rate to go down, because right now we only have assumptions on who has actually been tested, and we know that many more people have it than have been tested. But what we do know, again, putting our lens specifically on our elder population that are living in congregate facilities, is that the study out of Seattle is that mortality rate's about 37%. So for our elder population, this is very deadly. So I think we need to put on that hat about, is this really overkill? Are some of the things, are holding the mail, are stopping deliveries, is that really overkill? And we understand that this is really impacting our residents, but keeping them safe is significantly more important. So we can go ahead and go to the next slide. So I will briefly comment on this, that we do know that patients, or we believe patients can shed virus about 24 to 48 hours prior to showing symptoms. That is similar to influenza. There is a lot of suspicion about asymptomatic carriers. Of course, in our environments, we do suspect that if this is getting into the building, knowing that nobody's visiting, we're not getting deliveries, and that patients are not doing congregate facilities, probably the only way for this to get in the building at this point is either a staff member, perhaps a patient coming in from the hospital, somebody from the lab, or x-ray. So, and if those people who are presumably healthy are getting this, it's pretty mild. So they may not know that they have it. So whether they're truly like an asymptomatic carrier that's spreading this, or somebody that just has really mild disease and thinks they maybe have a little bit of a spring cold or allergies, they may be potentially a harbinger of illness. We also know, as I alluded to previously, that for every dozen cases that are diagnosed, we are missing significantly more. We just don't have enough tests right now. The infection cases are doubling about every 6 days on average. Though this data is a few days old now, I will note that New York is actually less than 3 days, and anyone who's following the news recognizes that their curve is very, very steep right now. So they're less than 2.5, I believe. And Washington State has gotten a little bit even longer. So our social distancing here that we're doing in the Pacific Northwest seems to really be working, and our doubling rates are getting longer, which is very good news. And then there are minor mutations that are occurring in the illness, which is what viruses do. They can outsmart us with those mutations. So, all right, you can go ahead and go to the next slide. So I want to comment a little bit about the signs and symptoms of COVID-19. We all have heard about the dry cough. We've all heard about fevers. And of course, fevers are used as a testing criteria at this point. But what we do know, the data coming out of Seattle, particularly with our elder populations, is that the fevers are actually not fevers. And for those, I don't know if there's clinicians on the line. I think that there's at least a few of us. I was always fairly dogmatic that a temperature is 100.4, and I'm not going to get too excited unless the temp is 100.4. But we know in our elder population that really what we need to keep in mind are trends. So a 2 degree above baseline is actually something to write home about. If somebody's running at 97.1 all the time and then suddenly jumps up to 99.1, that's a fever until proven otherwise if they're an elder or someone who's immunocompromised. So the testing criteria of making sure that they have a fever before you give them a test is out the window. So I'm urging facilities, as they're checking their twice daily temperatures, which I'm assuming everyone is doing at this point, and if not, you definitely should be, that you are tracking the trend, not so much the absolute number. So if you have a CNA who knows, oh, they have a temp of 99.3, and you're looking back at the trend and you're realizing, oh yeah, that's 2 degrees above baseline, then you need to immediately segregate that patient. And you need to do a workup and figure out why. So I will also comment that about 20 to 40% of patients have dyspnea, about 10% are getting nausea, vomiting, diarrhea, and then the rest of the time, or 15% of the time, is just kind of upper respiratory tract infection symptoms. And then if they do lab and x-ray, which would most likely be done in the hospital, we're seeing either high white blood cell count or low white blood cell count, but fairly commonly we're seeing lymphopenia, so low lymphocytes in about 80% of cases. We're also seeing kind of a viral type of hepatitis with the transaminitis, with the AST, ALT, and total bilirubin. On your chest x-rays, you are going to see the bilateral ground glass appearance. So we can go ahead and, I will note also on this data from the last couple of days is also noting a very predominant sense of smell and taste being lost. So again, it's allergy season, so that's pretty common for people with seasonal allergies, but definitely something to pay attention to. And if somebody has a low-grade fever and that could be reason enough to go ahead and give them a test. So I want to talk a little bit about treatment options, mostly because this has implications for the work that we do because of drug shortages. So I would not have the expectation that anybody in post-acute or long-term care or assisted living or adult family home is going to be treated with remdesivir, chloroquine, hydroxychloroquine, or azithromycin. Those should really be reserved for hospitalized patients who are the sickest. So, however, what this has implications for is for those patients who are chronically on hydroxychloroquine, you guys may run into shortages. Additionally, for those who use azithromycin for healthcare-acquired pneumonia, which is part of the standard recommendations, you may see shortages. So taking a peek at your PAR levels, whether you have a Pyxis or an Omnicell, making sure that you have enough of those to get you through if you do have the need for one of those medications. I also really want to heavily emphasize that the use of HFAs in lieu of nebulizers is recommended at this point if someone has COVID-19. The reason for that is that we know that a nebulizer procedure can potentially aerosolize the virus. So if you have patients that are suspect and they're on isolation, you need to ask the physician to ensure that they do a substitution for the nebulizer. And if that is not feasible, perhaps the patient has dementia or is unable for another reason to use the HFA, then that person needs to, or any staff members that come in, need to be using an N95 or CAPR or PAPR and have full, they need full PPE anyway, but a regular surgical mask will not work. So there is implications for those using nebulizers. Additionally, there's implications for shortages of HFAs. So what I personally have done is I am trying to preserve the HFAs in case I do get an outbreak, because I know that those patients will need the HFA, and I want to make sure that there's no shortages. So, and then I'll also comment, just because it is a treatment option that is getting more attention just this week, is the convalescent plasma. So this is plasma with IgG antibodies that are being given to patients, and they are having some success. So the N is very, very small at this point. The study that was published, was just 5 patients. But again, you guys may hear asks for plasma donations, particularly for patients who have gotten COVID-19 and then have recovered. So, so just something to be aware of. We can go ahead and go to the next slide. So again, I want to comment on the precautions. So what is shown up on the screen is actually WHO precautions. I will comment that the CDC is still recommending full PPE with negative pressure and N95. So if they are in your SNF and they're not doing an aerosolizing procedure, the WHO recommends following the specialized droplet contact precautions. That is goggles, masks, gown, and glove. If you are doing an aerosolizing procedure, that could be deep suction, intubation, aerosolization through nebulizers, then you need to have an N95, and it should be fit tested. There are many people that do not do well with an N95. I can tell you that I failed the universal N95 fit test. It doesn't fit me. So I have to have a small N95 or a duckbill. So for the standard ones that we're getting many donations from, for your people with a different face shape, it may not work for them. So there are online resources for how to do an N95 fit test. I encourage all of you to go to YouTube if you guys are using those. Make sure that anyone on your unit that would take care of COVID patients are adequately protected so they don't get it with the staff. Or if you guys do have access to CAPRs or PAPRs, certainly that is ideal, but those are in very short supply and clearly being used mostly in the hospitals. But important to make sure that our staff are protected. So we can go ahead and go to the next slide. All right, so I want to just comment that some of this is regional, but there are many requests through Department of Health, whichever state that you're in, for PPE. And as we know, they're being rationed. And at this point, if you are a post-acute or long-term care facility that does not have a positive COVID in your building, you're about 10th in line for PPE delivery. So why I talk about this is not to be so doom and gloom, but just to recognize that this is the current state and it is unlikely to change. And we do know that states at this point are competing for PPE. We have New York that is in a horrible surge at this point, and they're needing as much PPE as possible. So some of it is being shifted there. So we know that if you're in a negative building, that you are low priority. So now is the time to really get creative. And I'll give you an examples of some things that we've done in the Pacific Northwest. We are making our own masks. So our nurses that come into the facility, we are doing universal masking. They have a flannel backed mask with a pocket in it. In the pocket, we bought surgical sheeting, which is not in short supply since so many elective cases are currently on hold. You can still readily get that. And then we use that as an insert. At the end of the day, that's removed. The mask can go get taken home with the staff member, get laundered, and then come back and then use a new insert the next day. So that's one example that we've done. There's also the 100 million mask campaign. So I'd encourage people to look that up if you are in need of masks. that has a lot of volunteers making masks and looking at other options for how to get those. Additionally, we have asked our dental colleagues, nail salons, and we are asking them to donate masks. Of course, dentists are shut down in most states right now and cannot work, and they use surgical masks for every procedure, so they have a new mask for every patient. We've gotten a lot from our dental colleagues. And then finally, we have some area facilities that use reusable gowns, and a lot of them also service the restaurant industry. So the restaurant industry is very slow right now. And so businesses that previously did a lot of reusable gowns and laundering actually have time and a lot of availability of their reusable gowns. So we got contracts in place for those facilities and are now for gown access, having a recurring delivery set up for OSHA approved backless barrier gowns for reuse in buildings. So again, just some ideas there on how you guys can utilize some creative ways. This is what the CDC calls crisis interventions for low PPE. So clearly homemade masks are not ASTM certified or NIOSH certified, but we do know that we're in a crisis, and we know that that is at this point better than nothing, especially if we can get creative and use sort of the guidelines that are on the 100 million mask campaign or CDC website. I've heard also has some patterns for how to utilize these. So I will comment a little bit on employees and patients who are suspect cases because this has come up quite a bit. And because our public health departments are spread so thin, and because I have had a lot of interaction with them through the work that we've been doing with Multicare and PSW and my work as medical director, I wanted to go ahead and share that firstly, our public health department, they are the hub of this model. And so if you have suspect cases, whether it be a patient or an employee, we need to make sure that public health is central to that process. They're going to be the ones that help do your tracings and helping evaluate and potentially help get you tests if you have widespread cases in your building. So our recommendations, obviously, if you have a suspect case that is an employee and they're on rule out, they should be out until they have a negative test or it's been 14 days and asymptomatic. We also want to make sure that you then look back at all the patients that employee had contact and then cohort those patients and then make sure that they are on extra evaluation. But they shouldn't necessarily be with the general population. If you have only 10 patients that had contact with that employee who may or may not turn out to be positive, you don't want those residents, your patients who have never had contact with someone who is a person under investigation. So really being mindful of that, consider looking at your physical plant, evaluating if you can make special units for isolation or perhaps reverse isolation. So I can tell you that we have worked with a facility to do that where they had a number of patients who were asymptomatic. So those were the patients that got isolated onto a special ward with special staff. And so I'm really looking at the capabilities there. Additionally, with patients, if you have suspect patients, making sure that they are isolated. If you can put them in a separate unit, that would be ideal. Clearly, you don't want to be moving them throughout the building. So if you have to, clearly you need the patient to have a mask on, but clearly the hope would be that you keep that patient in place and then you move everyone around them. So the patient who is positive or suspect positive doesn't have to move and spread it through your building. And I'll talk a little bit about antechamber capabilities, but looking even at Home Depot or Lowe's, Ace, if you can look at the zip walls or other physical barriers that you can put up, and that is sort of your unit, that then you can don and doff PPE at the zip wall before you enter what would be a respiratory unit, with the understanding that you're not going to be able to change PPE between every positive patient. So once you step onto a ward, if you have multiple positive or suspect cases, you're going to have your same shield or same goggles, same mask, same coverall, whether it be a full bunny suit or a gown. And then the only thing you're going to be changing is gloves in between that, because you have to preserve PPE and you also want to protect yourself and not be having to touch your face to take off your mask and your goggles between each patient. So again, sort of thinking ahead about how you guys will do that, practicing, particularly practicing with role play and donning and doffing PPE and that sort of thing is super important with your nursing staff. So we can go ahead and go to the next slide. So again, this is more what I talked about on the last slide. We definitely want to make sure that you have the ability to cohort symptomatic patients. rigorous infection control guidelines. So what the experience has been fairly nationwide, I think, at this point, but definitely in Washington State, is that once you report a positive or a suspect case from your building, whether it be an employee or a patient, usually the state will arrive in your building within about 48 hours to do an infection control investigation. There have been very few facilities with positive cases that have escaped citations. They're citing people on IJs and widespread, from everything from missing a step and donning and doffing PPE to not having a backup medical director. So really evaluating your regulatory processes and understand that the state will likely be there. I know that they're doing both preemptive visits to prepare, which is good, but then they are also going to follow up if you have positive. So making sure that all of your staff really know how to don and doff PPE, make sure that they know the hand washing for 20 seconds, gel in, gel out. I will comment, again, it's not infection control guidelines to reuse PPE. So nobody wants to get attacked for that, though I think most regulatory bodies understand that we are, of course, having to reuse PPE, but making sure that you have some sort of policy and procedure related to that, or you QA the process on the restricting, reducing, and reusing. So that's the term from the Institute for Healthcare Improvement. You guys can simply Google IHI, restrict, reduce, reuse PPE. It can give you guidelines. I also have it if you guys want to send an email to the organization. We can definitely get that or put it on our portal for you guys. But essentially, it's talking about how to reuse them. For those using N95s, it recommends using them up to 5 times. You put them in a paper bag outside the patient's room, write the staff member's name on them, write 5 boxes, and then check them off. And then after 5 uses, you need a new one. I can tell you that I used the same N95 for about 2 to 3 weeks before I got a new duckbill one to use. When we had multiple suspect cases that I was dealing with. So we do know that we are in a position to have to reuse them, and we do understand that they are meant to be single use, but we just don't have enough. And then again, I already recommended making sure we're using public health as a hub. So if you have any suspect cases, please make sure that you're in close contact with your public health department. All right, we can go ahead and go to the next slide. All right, so I did want to include some of the PPE donning and doffing. So this information came out of Providence, actually, that used some new CDC recommendations. And this is a double gloving procedure, which many organizations do not have on their policies and procedures, but it really makes sense if you're going into COVID units. And I can tell you that this is what I have personally done in that scenario. So I think it's important to recognize you need to remove your personal items. So as you guys are looking ahead at if you have a COVID unit or have positive, asking for nurse and CNA volunteers to work on that unit is recommended. Making sure that they're not wearing their rings. I can tell you I've been ringless for a month. I haven't worn a watch in a month, and my hair has been in French braids. So making sure your hair is tied back, that you don't have any personal items on you. I've been wearing a surgical cap to make sure that my hair is back, again, because anything like this, or a stethoscope, a white coat, anything is a fomite. For those of you who are not familiar, fomite is just any inanimate object that can spread illness. So that's back to that plastics for 72 hours comment earlier. So you're going to perform hand hygiene. You're going to put on your inner gloves first. Then you're going to put on your barrier-proof isolation gown, whether it be a reusable one or not. Then you're going to put on your mask, your goggles, etc., making sure if there's any possibility of aerosolizing procedure, which I will say does include CPR, that is considered an aerosolizing procedure, that you have an N95 that has been properly fit tested if possible. And then either your visor or goggles. I've had multiple questions on, are just like the regular goggles fine? They are, as long as they wrap all the way around. Regular glasses are not considered appropriate PPE. So anything that you would wear in the operating room, which are like regular goggles, they don't have to be the chemistry lab goggles, but those obviously work. But I can tell you that I was wearing my yard work goggles at one point because I wanted to make sure to save some of the new ones for my nursing staff. So as long as I go all the way around and fit your face, that's perfectly appropriate. And then the last step is putting on your outer gloves. So we can go ahead and go to the next slide. So the PPE doffing is actually the trickier part, and I will tell you I practiced this multiple times. I also went through it with my nurses. We did some role playing, and we were mimes because we didn't want to use actual PPE and waste any. But this is sort of a hard process to get down, and so it does require practice. using Socratic method, asking your nurses what they're going to do, and really running through this and practicing. So when you come out of a patient room, if they're COVID positive, and so for this example, I'll use, it's just one person, you're not like in a full unit. You're coming out, you're still in the patient's room, you're done perhaps doing a test or doing an exam. You're going to sanitize the outer gloves, then you're going to remove your gown, gentle motion away from the body, never pull the gown over your head, okay? And of course, be mindful, if some of you are using the reusable ones, you're gonna have to reach back and untie it. If it's the disposable ones, you can just break it and then throw it away. After you remove your gown, then you're going to remove your outer gloves, which have already been sanitized, okay? So at this point, you have inner gloves and you have all of your face shield on, and then you're, presumably in scrubs or whatever. You're then gonna disinfect your inner gloves before you exit the room. Then you're going to exit the room, and when you're outside of the room, that is when you will remove your mask, your eye protection, and then you're going to have to clean and disinfect them because you're reusing them. So using your micro quick kill or your purple top tub to disinfect all of your PPE, hang it on a hook. So I can tell you in our designated COVID unit, we just went and got a bunch of 3M hooks. They're all hanging on the back of the door and on the fire door, and then we can hang them all up there. We wrote our names on our gowns, and then we can reuse them. So only after that point, then do you doff the inner gloves that you were wearing, okay? Then you perform the hand hygiene, and then you're done. So the separate scenario here is if you have multiple positive patients. So I can tell you what I just did in this scenario when I went in and tested multiple patients who turned out to be positive. I had the same PPE on. I had to wear the same PPE for every single patient. There's no way that you can don and doff between each patient, especially when you're trying to go through and test and perform care. It's not safe for me to have to touch my face every time after dealing with positive patients. And again, there just isn't enough PPE. And presumably, if you have a couple of patients positive in a building, then you likely have more. So in this scenario, I didn't do the doffing of the mask and the eye protection and the removal of the inner gloves until I was all the way done. So the only thing I did between patients is I would come out of the room. Or before I left the room, I would sanitize the outer gloves. I would remove the outer gloves, throw them in the garbage by the door. Then I would be out in the hallway. I would sanitize again the inner gloves. I would put on a new pair of outer gloves, and then I would go to the next patient. If there was any soiling in between, which luckily there wasn't for me, we had microkill on our cart that we were taking with us, and we would just microkill. I had like a Tyvek sort of bunny suit on, and you could microkill all of that. And then I had a capper, so I did mask and helmet. So those are just examples. Okay, and I'm just checking to see if there's questions, and it doesn't look like too many have come in yet. So we will go ahead and go to the next slide. I will comment that there was a lot of information about the Abbott test that came out over the weekend. Of course, we were super excited about this. It is fairly hard to come by. If I had my way and I could wave my magic wand, every SNF would have one of these so they could do rapid testing. It takes 5 to 13 minutes. Again, these are hard to come by. But I do think that it is worthwhile to point out that the study just published on Sunday that came out of the Seattle experience, or the Seattle area experience, is that symptom-based screening misses over 50% of positive patients. So in the scenario where you have a couple positives in a building, if you are only doing symptom-based screening, you are going to miss people. So if you get positives in your building, you want to screen everyone, including staff if you can. Again, I know that there are probably some people on the line thinking, oh my gosh, we don't have the equipment to do that. We understand. Again, that's engagement of your public health department to see if they can help with testing. That's exactly what we have done in the facilities that I have been involved with in this exact scenario is universal testing. And inevitably, we came back with multiple positives for people that we didn't think were positive. So I think that if there's anything that you can prepare for, if there's a way to order more tests, contact your lab now. Make sure that you have enough tests to get all of your, if you're in a 100-bed facility and you're running an average census of 90, see if you can get 90 tests at least, and then figure out how you're going to test the staff as well. We do, of course, recognize the need for rapid testing. Depending on what area you're in, tests are still taking anywhere from 5 to 10 days if you have to use a private lab. Again, the benefit of engaging public health where they can send it off. Also, the benefit of engaging your hospital system, depending on what area you're in. asking your hospital system for help. It behooves them to help their post-acute and long-term care facilities as well as their adult family homes and assisted living. All it would take would be one assisted living or one long-term care facility to get this, and it could overwhelm a hospital system in a matter of hours. So we really want to be good partners with our hospital systems on this and see if they can help support the skilled nursing facilities and congregate facilities as much as they can with helping to run tests if they have the capabilities, offering PPE, offering support when needed. So now is really the time, if you haven't done it already, to try and engage the hospital leadership, the case managers, and those departments. Okay, and we can go ahead and go to the next slide. All right, so I do want to comment a little bit, and I know that I've been on the phone with a couple of nurses who may or may not be on today on how to train people to do this. And so I said that I would stay on after the webinar so we could be on video so I could go through it with everyone. But I do think it's important to make sure that you have a subset of nurses or your physicians, nurse practitioners, PAs, who can come in and do widespread testing. So this is developed from Multi-Care Health Systems, and it is example of how you would want to do the testing. So I do think it's important to put the mask over the patient's mouth first, because if they cough or sneeze, that'll help protect you. So you're going to provide the mask to the patient, you're going to have them put it on, lower it down below their nose, and then hold it if they're capable. At that point, with your full PPE, and you can see there the patient or the clinician has a visor, gloves, and a gown, as well as a mask. The only thing I would comment on there is it would be ideal if they had hair covering, though obviously he has short hair. At that point, you're going to use your Dacron swab. So this is the same type of swab and viral media that you use for your flu test that you send off. So the red top tube and the Dacron swab. You're going to do a nasopharyngeal to do this. So what most people don't realize is that you have to go back further than you think. So you are going to measure from the anterior nair to the anterior part of the nose. You're going to take half that distance, so about right here. And so, and I know it's hard to scale when I'm on a video on an iPad, but this is about the distance that you would have to go in terms of the depth of that Dacron swab to get it back into the nasopharyngeal area to get an adequate sample. So when you go in, you're going to take the Dacron swab. You sometimes have to go up just a little bit to get in the right space, but then you're actually going to go parallel to the hard palate. So you're going to try and go straight back. You don't want to be going up because you can hit the cribriform plate. So you're going to be going back and parallel to the hard palate. You're going to want to twirl and try and leave it in there for several seconds. So I've had questions on, do you have to do it both nairs? Do you just do one nair? One nair is fine. You just have to get a good sample. If you don't feel like you got a good sample, then you need to move to the other nair and do it again. Additionally, sometimes it's a little bit hard. Like I personally have a deviated septum. And so if you're going back and you're meeting some resistance, then pull out and go to the other side because they may have a little bit of a deviated septum. So it's definitely worthwhile to make sure that all of your nurses are trained. Helpful if you go through a checklist and then sign the nurse off so they can have it for their records, again, from sort of the regulatory perspective. And if state comes in and does sort of their preemptive visit, you want to let them know, yep, we have multiple nurses that have been trained, they've been signed off by the physician or the medical director or whomever, and they're ready to do this. So again, very important. We do not want to get inadequate samples and then have false negatives. That's about the worst thing that could happen. So you really need to make sure that you get a good sample. You really need to make sure that those nurses know how to don and doff the PPE and that they are fully protected when they do this procedure. All right, we can go ahead and go to the next slide. All right, so what I will talk about, and again, I know that we have people sort of all over the country who may be listening to this, but what came out of the Seattle experience was really the need to categorize admissions. So I had mentioned earlier that in conjunction with the University of Washington Harborview and Swedish, a category of admissions came through. And this was to help facilitate referrals, to make it easier for the receiving facility. So category 1 through 4, this should be listed on the referral as well as in the SNF transfer summary. So this has many, many benefits, including for the facility. So you don't have to pour through 20 pages of hospital records to see if a patient was tested and if they were negative or not, because that's such a time drain. Additionally, it has benefits for the hospital system because they're feeling like they have to do exhaustive documentation to prove to a SNF that a patient doesn't have COVID. So what this does is it makes it very easy. You categorize the patient as 1, 2, 3, or 4. Category 1 is no concern for COVID-19. Examples of this would be somebody fell and broke their femoral neck, their status post-hemiarthroplasty. They were in the hospital for 3 days, they got surgery, they now just need post-acute rehab, maybe they live alone or whatever. So this would be a Category 1 person. There's no expectation that they will have a COVID-19 test. It's an unrealistic expectation for the facility to ask for a COVID-19 test, particularly with the shortages. So this would come through as a Category 1, so you guys can categorize whether it is appropriate for you to take those patients or not. Category 2 is someone who did present with respiratory symptoms, but they had a COVID test done. It's negative. They're Category 2. They're ready for discharge and have rehabilitation needs. Again, this should be fairly easily identifiable, so you don't have to go through 20 pages of admissions paperwork or medical records from a hospital to try and figure that out. It can just say Category 2 on the referral and then Category 2 on the SNF discharge summary. Category 3 is a PUI, or what some hospital systems are now calling rule-outs. So they are a suspect case and their test is still pending. Category 4 is they are actually a COVID-19 positive patient. The recommendations coming out of UW is that they have been 72 hours symptom-free or 7 days without symptoms, whichever is longer, and that they have been cleared by the health department to be discharged from a hospital to a congregate facility. So clearly from a public health perspective, we don't really want to discharge COVID-19 positive patients to a facility that has absolutely no cases. Why would you want to introduce it to a facility that doesn't have cases? So the hope would be if your facility already has positive cases and you're set up and you have capabilities, you have PPE, you have staffing, then you are willing to accept these patients in and you have the ability to do rigorous isolation protocols. Same for your PUIs. You know, if this person came from your facility and they potentially got COVID at your facility, got sick and are now better, and COVID is already in your building, then it would certainly be the expectation from the hospital system that if you have staffing and capabilities that you would take that patient back. And so I'm sure most of you guys saw the AMDA statement and ACA statement on what New York is doing, where they're putting a lot of pressure on the skilled nursing facilities to take these patients. And I think if you guys haven't read that statement, it's very worthwhile. It is very common sense. It simply says we are not going to just mandate the post-acute and long-term care facilities that have the most vulnerable patients take a slew of COVID-19 patients when they don't have it in their building. That there are multiple moving parts related to if these patients can be accepted by a facility, including do you have the ability to keep your staff and other residents safe. So very important to consider. But again, as we look at streamlining this process, particularly in hospital surge capabilities, we want to make sure that it's as easy as possible for both our hospital colleagues and our skilled nursing facility colleagues. No hospitalist in this era wants to spend, hours with exhaustive documentation if they can just put, yep, they're a Category 1 patient, no COVID-19 testing. I will say that it's important to note that many facilities have asked me about what my recommendations are for patients coming from the hospital, knowing that they're likely coming from a system with positive cases. And so this is something that's not rooted in evidence. This is something that many people are doing, and they are still putting those patients on contact precautions. And of course, they're universally masking anyway, so they have a mask that they're wearing to keep those patients isolated in a separate unit, knowing that even if they went with a hip fracture and got a hemiarthroplasty, they were just in a facility that likely has positive cases. So I think it's important to look at your capabilities, look at what you guys are doing, and identify case-by-case basis, of course, with heavy involvement from your medical director on what makes the most sense given the current circumstances. To my knowledge, though certainly someone can pipe in, there have not been any formal recommendations from the CDC, the Department of Health, or ACA or AMDA regarding this. But it is definitely the feeling from many of us that we would feel safer if those patients are on contact precautions and have congregate staff and that they're not mixing, particularly if you don't have any negatives in your building. So hopefully that makes sense to everyone. Okay, we can go ahead and go to the next slide. Oh, there's that statement. There we go. So, and again, this is everything that I have already stated. This was dated Sunday, March 29th, and I think ACA just came out with another recommendation perhaps yesterday. So just make sure that you guys have this available. Share it with your corporation, share it with your medical director, and identify what makes the most sense for you guys on how you guys are accepting patients back from hospitals. Okay, you can go and go to the next slide. So we just have a few slides left, and so I want to save a little bit of time for comment on shared decision-making and pulse form inventory. So clearly it will be very helpful for our hospital colleagues if every patient comes with a pulse. And I know for many skilled nursing facilities, this is fairly common practice. That's debatable whether we should be doing that from a palliative care perspective, but I know from a regulatory perspective, this is oftentimes the easiest thing to do from a systems-based perspective. I'm not advocating for that one way or another. However, in this era of COVID, we do know it's very, very important that we have shared decision-making conversations, so we are not doing things to patients against their wishes. So if you have a group of patients, particularly this applies to your assisted livings and your adult family homes, if you have multiple patients who are elders and they don't have pulse forms and you don't have their wishes, now is the time to start talking with their families so you are not doing things to these patients and sending them to the hospital if that's never what they would want. So I can tell you some of our experiences from the hospital side is that we had a 99-year-old and a 96-year-old sent in over the weekend, and they had presumed positives and they were going to the ICU. So whether that was those patients' wishes or not, it's very difficult to know. So just making sure that we are doing things for patients and in accordance with their wishes instead of doing things to patients because we don't know, and so we're having to do it by default. So examples for those of you who use PCC, you can run a quick inventory. You can look at all the patients that are full code, make sure that they are truly full code. Does their pulse form match that? Is it appropriate? Is that really what they want? Is that what their family wants? I will comment that Respecting Choices came out with a proactive care planning discussion for COVID-19. So this is very, very helpful to drive discussions and having those critical shared decision-making conversations with patients on what they would want. Again, knowing that the mortality rate is so high in elders, to 37%, and we know after intubation that these patients don't do as well. So again, having those frank conversations, and I know it can sometimes feel a little bit forced, but just understanding that this is super important. And this makes all the difference in the world if the patient comes with that green pulse form into the emergency room or comes in and is an unknown. So this is really going to make it easier on our emergency room physicians, our hospitals, and our intensivists so they know the wishes of the patient. Of course, with the understanding that they can change that at any time, but certainly helpful. I will also comment, they're in orange, these are property of the patient. If the patient has a pulse form in the hospital, they absolutely should come to the skilled nursing facility or adult family home or assisted living, wherever your congregate facility lies. Likewise, if you have a pulse form, do not make a copy for the medics and send the patient with a copy. The original goes with the patient. It is the patient's property. So making sure that we are following, guidelines on that this does belong with the patient. Same when they get discharged. This is the patient's document for them to have. All right, we can go ahead and go to the next slide. All right, so I will comment on this. I will say that this has been fairly well received by many of our facilities. That heaven forbid if you do have an outbreak, or maybe you don't have an outbreak, but you're just hitting crisis staffing levels because maybe you have multiple employees are out, maybe because they have to stay home with their kids or whatever. If you're running one nurse to 25 patients or even one nurse to 10 patients, but all 10 of those patients have COVID, the last thing that we need to be worried about is having a 6-hour med pass. So we know that multivitamins and statins and a lot of complementary and alternative medicines, those can really slow down med pass. And we, of course, want to be very mindful of patient rights, and we want them to be able to get what they need. But in a crisis scenario, seeing if you can get your medical director to do a standing order to hold these medications. In the event of COVID and you're on a COVID unit, hold X, Y, and Z. And here, this is a list of 11 medications. This was formed with an interdisciplinary team of nurses and a pharmacist, and we all worked together on what was the most reasonable. If you have one nurse to 25 patients and you need them to be doing, Q-shift vital signs, including O2 sats and managing, the oxygen concentrators, you don't want to have to administer 13 vitamins in addition to, 6 crucial life-sustaining medications. So again, this is meant to be sort of a short-term fix for a crisis scenario, certainly not to be abused and certainly not to go against patient rights. Having those preemptive conversations with them. I can tell you patients that are admitting at this point, as I'm admitting them, I am kind of giving them a primer like, hi, I see that you're on multivitamin and you're on folate, and I know that you like your estrogen and you have this other medication. I just want to let you know that if we hit a critical staffing level, the nurses have my permission that we can hold those for a day or two or until we can kind of get back to normal levels. And I think as long as you do that level setting ahead of time and you sort of preempt patients, most of them are very reasonable and they say, oh, of course, like, please, if I have to go without my statin for a few days, it's fine. We purposely didn't put thyroid on here. We know that nobody will go without their thyroid for a couple of days, even though you theoretically could. But we know that that is not well tolerated, especially with our elders. But these are sort of reasonable medications that if they go a few days without this, it's not going to be a make or break situation. And in fact, maybe in the end, it'll help their constipation and all the other stuff that they have by not getting a bunch of medications, and maybe they'll feel better. But anyway, something to consider operationalizing for those of you. And again, making note that some of these are, especially the artificial tears, that's for comfort in end of life scenarios. And of course, we're still encouraging compassionate visits and all of that. So that is an outlier in this situation. So, okay, we can go ahead, and I think we just have a final slide maybe. Yeah, so this is more just the touchy-feely part of what we do. So particularly those in Western Washington, we are doing an artwork for elders campaign. So you guys may start getting letters from elementary school students or others who are at home. We have given instructions that they may hold them for 24 hours, that they are not to lick the envelopes. But these are just little letters or artwork from elementary school kids who are home and being homeschooled and asking their parents and teachers online to do things like this. So you guys may see a slew of mail hopefully coming your way for your elders who we know are fairly socially isolated at this point, and we know that that's really hard on them. Additionally, the Hope Grows Here campaign originated out of Pierce County region in Washington State, and I thought that this was just a really good idea for your activities coordinators to do for those in your building. There are so many residents who, again, they are socially isolated, but this is an isolating activity that they can do on their own. Give them some art supplies, have them do letters, have them do flowers, and the hashtag Hope Grows Here, so they can put them on their windows. For people, and that makes them feel good. So again, I think just kind of little ideas for those of us to take a breather and see what we can do for our elders who we know this is a very difficult time for them, not having visitors. And of course, we know that there's a lot of goodwill going out there about the iPads and the FaceTime visits with their family, and that's just making such a huge impact on their social well-being. So we do want to make sure that we're being very mindful of that as we look at this difficult time. So thank you guys so much. I will pop on the chat here, and I do not see any questions. We have about 6 minutes, so certainly if anybody wants to unmute themselves and ask questions, please feel free, or you can text them in. I did promise that I would stay on a little bit to, again, do another demonstration on the nasopharyngeal swab, so I'm happy to do that as well.
Dr. Van Fleet Green, this is Emily, and I did get one chat to the presenter chat. It's from PNR, okay, who asked, can 2 patient rooms be used, clean and dirty, for antechamber process for donning and doffing PPE?
So what I think you mean, so this would be an empty room that you would then have a donning and doffing chamber before you went into a unit. And yes, absolutely, if you have the room, I think that that's ideal, and then you don't have to be doing it in the hallway. I also think it's a really great thing to put all your supplies in there, so you can have the purple top and the micro kill in there. You can have your dirty linens. That can be where they come in and pick things up. So excuse me, I think that that is an excellent idea, and certainly ideal if you have the physical plant layout for it. So I can tell you in the work that I've been doing, we've been going over physical plant layout and just sort of getting creative with our facilities on how you can do this. And that has been an example in multiple cases is using an empty patient room and sort of having that as the barrier before you go into multiple positive areas. So hopefully that answered that question. If not, feel free to text in or again, unmute and chime in. Happy to talk through that with anybody. Okay. So again, I commented that I would stay on for just a couple minutes and go through the nasopharyngeal swab one more time. I don't have any nasopharyngeal swabs with me, but again, I'll just walk through just using the pencil as the example. So if the patient is turning to the side, again, you're going to measure from the anterior nair to the anterior ear, and you're going to look at about half that distance, and that is the depth that you need to go for the nasopharyngeal swab. So as you are looking at the patient, you're going to make sure that they have their mask, and you are going to, yep.
Hey, this is Ashley at Puget. Could whoever's presenting, could they please put you on as a shared screen? Because right now you're about 1/8 of the, or less of the screen. We can't see you.
Oh, okay, let's see.
I will display the screen.
Oh, good. Oh, so I'm going to be big now. I don't think I can do that on my side. So Emily, if you just close down the presentation, can you make me big?
Yeah, sorry, I can see right here. I'm just trying to get you to be larger.
Oh, did that work?
Is that helpful?
Oh, you're still small. You just have to click on her. Yeah, you're still
no,
small.
You may actually be able to do it on your screen, Ashley. If you make the PowerPoint smaller, you may get me bigger.
Well, we have it broadcasted from the GoToMeeting, but every time I'm clicking on you, I have no host access, so that's why. We're just a participant access.
Yeah.
Yeah, I apologize. Clicking on your screen isn't making you larger either, so I'm not quite sure.
Okay, I just got myself larger by doing that, by minimizing. There's like a little gray line, big gray line with two little black lines. And if you just move that down on your screen, suddenly the two videos get large.
Yeah, I have no.
And if that doesn't work, no way to do that. Okay, this is what we'll do, Ashley. Why don't we just dial in? And so I will have you go ahead and Emily, what's the best way to get her the contact in? We'll just do a FaceTime, and I can work with her staff to show them how to do this.
You just want to FaceTime Mag?
Yep, I'll do that. I'll do that.
All right, thanks.
Okay, Ashley. All right. Any other questions before we get off?
No, we'll talk to you in a second.
Okay, sounds good. Thank you all.